Welcome to the International Center for Research on Women's Insights to Action event entitled Navigating the Intersection Between Gender and Adolescent Mental Health. My name is Jacinta Kapungu, and I serve as Senior Gender and Youth Specialist at ICRW.
My name is Christina Juan, and I serve as Gender and Health Specialist at ICRW.
This is a culmination of efforts led by our former Portfolio Director, Suzanne Petroni, which began with the technical convening of experts focused on the intersection between gender, adolescence, and mental health. We recently published a white paper entitled Understanding and Tackling the Gender Drivers of Poor Adolescent Mental Health, which can be found on the ICRW website. Our objectives for this webinar are to understand the relationship between gender and adolescent mental health, and also to discuss priorities for research and action to improve adolescent mental health by focusing on gender. And we talk about gender, we talk about it as gender roles, gender attitudes, and gender norms. The words sex and gender are often used interchangeably, but they are not the same thing. There are important distinctions between the two concepts. Sex refers to the biologically determined characteristics of men and women in terms of biological differences, chromosomes, internal and external sex organs. As such, sex is globally understood as male or female. Gender is a social construct, that is, a society's assumptions about the way a man or woman should look and behave. It refers to the roles and responsibilities, the norms and expectations of men and women and boys and girls, which are created within families, societies, and cultures. Gender includes socially derived expectations about the characteristics, aptitudes, and likely behaviors of women and men, girls and boys, also known as femininity and masculinity. Gender also goes beyond the binary concept of female and male and should really be seen along a continuum. Therefore, gender is also about how gender expression and gender identity intersect in multidimensionally array of possibilities. People express their gender identity as a woman or man to varying degrees along a continuum, with some people, for example, identifying as neither a woman nor a man. We also know that gender identity can change over the life course. The WHO stated in 2014, gender is a critical determinant of mental health and mental illness. It determines the differential power and control men and women have over the socioeconomic determinants of their mental health and lives, their social position, status, and treatment in society, and their susceptibility and exposure to specific mental health risks. Gender norms, roles, and relations can influence multiple health outcomes and affect mental, physical, and social well-being. Girls living in low and middle-income countries face a variety of social and culturally driven factors that place them at poor health during adolescence. Adolescent girls, in particular, can have limited opportunities or be devalued because of gender bias and low social status. For instance, in some countries, girls are more likely than boys to be married as children, drop out of school, or be at heightened risk for HIV and AIDS and sexually transmitted infections and violence. Gender norms can also influence girls' ability to negotiate safer sexual practices, such as using condoms, because of unequal positions in relationships. Gender differences also exist in morbidity and mortality, which include biological factors such as hormonal influences on physiology and behavior, and environmental factors such as cultural influences on gender differences and health behaviors. Cultural expectations of what it means to be a man may lead boys to engage in risky and harmful behaviors, such as drinking and illicit drug use, or less inclined to wear helmets or drive fast. Gender differences also occur particularly in the rates of common mental disorders, such as depression, anxiety, and somatic complaints. Girls and women are at increased risk for depression, and suicide is the second leading cause of death among adolescent girls because of self-harm. Gender inequality can also limit access to quality health services, such that women lack the power of decision-making to seek health care services. They may need to receive permission either from the head of households or their husbands, or they may have to be accompanied by a male member of the family to get treatment. For men, they may be less likely to seek help for treatment. These gender-related barriers can contribute to avoidable morbidity and mortality rates in women and men throughout the life course. Limited access to resources and power can also limit their opportunities to thrive. In low to middle income countries, mental health is shaped by various structural, neurobiological, psychosocial, environmental, and economic factors which impact the way people live. Gender inequality or unequal treatment or perceptions of individuals based on gender create, maintain, and exacerbate exposure to risk factors that impact mental health. These gender inequalities can arise from differences in socially constructed gender roles. Rigid and harmful gender roles and norms differentially impact the mental health of both adolescent girls and boys. As we know from the Lancet Commission on Adolescent Health and Well-Being, adolescents are biologically primed to begin engaging more with the external environment. So images and expectations of what girls and women, boys and men should be have tremendous influence on them during this time. At the same time, neurobiological changes that take place during adolescence, in particular beginning at puberty, create changes in the brain and body that pose different risks for girls and boys. They become more emotional, more prone to take risks. These behaviors can clearly influence how boys and girls absorb and act on gendered norms and expectations. On the psychosocial level, during adolescence, young people also learn how to form safe and healthy relationships with parents, teachers, and romantic partners, at the same time navigating expectations about appropriate gender roles. Media has become extremely important in the lives of adolescents. They've spent a significant amount of time viewing and interacting with media in the form of television, video games, music, internet, and on social media. Gender stereotypes are often incorporated into media and advertising, which very often reaffirm traditional gender roles. Gender also impacts structural factors such as access to education, access to healthcare, and income, with girls disadvantaged due to their status in society. So how do gender roles and norms differentially impact the mental health of adolescent girls and boys? Well, research has shown that puberty can trigger psychological stress for both girls and boys. It is during this period that depression-related illnesses peak in adolescence, as gender norms are also being developed. In early childhood, girls are no more likely than boys to evidence depression, but after puberty, the risk of depressive disorders increases drastically, and there is a significant gender gap, with females being between 1.5 and 2 times as likely as males to be diagnosed with depression, both during adolescence and throughout their life course. Adolescence is also a time when boys and girls are affected by social norms and expectations based on their gender and sexuality. Puberty intensifies social expectations from parents, peers, and in their communities. Girls and boys are treated differently, and rigid gender norms can negatively affect both boys and girls. Girls may be limited by where they can and cannot go, have household responsibilities, and be unable to attend school, whereas boys can travel freely and can obtain income. Traditional gender roles are a driving force behind women's lower economic status, low literacy and education, poorer health outcomes, and greater exposure to gender-based violence. There also becomes increasing pressure for adolescent girls and boys to conform to these culturally sanctioned gender roles. Gender intensification has been viewed as an explanation for the emergence of the gender differences in depression. Gender role conflict evolves, whereby adolescents have difficulty with the gender roles that have been traditionally ascribed to their sex. For example, a girl may conform to the traditional expectations of her family to get married, even if she has other aspirations. Girls are often among the most socially and economically marginalized members of communities, and evidence suggests that such marginalization can contribute to greater risk of suicide. Girls and boys who are of a different sexual orientation or gender identity than what social norms or laws allow may face greater risk of depression and suicide. Data from high-income countries demonstrate a link between gender role conflict and increased risk for suicide. Girls and boys face different risk factors which compromise their health and which could be influenced by gender roles. This slide shows the highest causes of death for older adolescent boys and girls according to the Global Burden of Disease. The columns on the right are from 2013. And if you look at this column, these are the causes of mortality, and I will look at it from a gendered lens. Are boys dying of road injuries and violence, not only because as adolescents they're hardwired to take risks, but also because they think it's socially expected of them to drive fast, not wear helmets, and to fight in order to prove their masculinity? Are girls dying of fire and hot substances because they're the ones in the kitchen or over a cook stove for hours each day, cooking food for their families because that is expected of them? Or perhaps they are actually dying of self-immolation, which would otherwise be characterized as self-harm, but it is not because of the stigma associated with suicide? HIV-related mortality and new HIV infection rates have declined significantly in the past two decades for every population except adolescent girls. Not only are girls more biologically prone to HIV infection, but there are many social factors that put them at risk as well. And hopefully, we all know by now that suicide consistently has been one of the leading cause of death globally for adolescent girls and boys, which is part of the impetus for this Insights to Action event. My colleague Christina Wan will talk about the Violence Against Children survey.
At ICRW, we have been collaborating with Together for Girls to lead a multi-country analysis of the Violence Against Children surveys that primarily focus on issues of violence against children in low and middle income countries. Here's data from the VACs for 6 countries, which demonstrate the difference in suicidal ideation, so having ever considered killing oneself, between adolescent females and males ages 13 to 19. In countries like Cambodia, Haiti, Kenya, and Malawi, girls are more than 2 times as likely to have suicidal thoughts. For another look at the mental health of these populations surveyed through the VACs, we also looked at associations with mental distress. So here, we're looking at the distribution of mental distress by level of severity among adolescents using the Kessler Six Scale, which is a validated measure often used in high-income countries. This Kessler Six, also known as the K6, poses 6 questions to assess levels of mental distress on a 4-point Likert scale. The questions examine feelings of hopelessness, restlessness, worthlessness, depression, effort, and sadness experienced by the respondent during the past 30 days. Across the 3 countries, prevalence rates of moderate mental distress among adolescents range from 25% to 55%, which is extremely high. When you look by gender, in Cambodia, girls are reporting higher levels of moderate mental distress. When you look at Haiti, there's a gender difference in reporting of severe mental distress. This means that adolescent girls in Haiti are disproportionately affected by experiences that lead them to levels of severe mental distress. These figures are glaring, and we want to understand why. What's also important is not only shedding light on the adolescents who experience severe mental distress, but also taking note of those who experience moderate mental distress. Based on our preliminary Haiti analyses, adolescent girls have a higher odds of experiencing mental distress in the past 30 days if they've ever worked, are wealthier, or have experienced multiple forms of violence in the last 12 months. We also found strong statistical evidence of association between suicidal ideation, mental distress, sexual and reproductive health behaviors such as ever having sex, and having experienced multiple different forms of violence in the last 12 months. In terms of our investigations around gender, through our analyses of Haiti VACs data, we found that there's no evidence of association between the individualized gender attitudes measure, a portion of the gender equitable men's scale, known as the GEM scale, and mental distress and suicidal ideation in our various models, after accounting for various risk and protective factors and other variables we think can help explain adolescent experiences and severity of mental distress. As noted, the gender attitude scale that we analyzed in the VACs was a portion of the complete GEM scale, which includes 24 items. The VACs wasn't designed to examine the role that gender attitudes and norms plays. Our research and analyses at ICRW help demonstrate that we need more information on the role that gender plays on adolescent mental health. Few research, programmatic, and policy approaches have effectively addressed the gender-specific mental health needs of adolescents and their vulnerabilities to depression, self-harm, and suicide. More research and programmatic action are needed by the global and health communities to appropriately respond to poor mental health among adolescents. We want to identify priorities and recommendations that provide opportunities for action. So here are just a few ideas that could be a starting point for this discussion. There is an array of things that we can do together. In terms of research, we have the opportunity to do a systematic review of adolescent mental health work that exists, programmatic reviews, secondary data analyses like the VAX and other data sets. Scale development is one area that we're particularly interested in based on the data that we've seen so far. For example, what we'd love to see is more of an understanding of the current gender and mental health scales that are used in population-based surveys. We have rigorously tested and validated scales in high-income countries. Further research and standardization is needed in low and middle-income countries with a focus on mental health and gender domains that are relevant within local contexts. In the same vein, we can also generate evidence through qualitative and quantitative research as well as pilot test interventions. In terms of programming, we have the opportunity to integrate gender in adolescent-friendly services, adapt materials, teaching, and learning curriculum, for instance, gender-sensitive programming specific to parent involvement in schools for a more supportive environment for adolescent boys and girls. We can also work closely with frontline workers to understand gender-specific risk factors. Mental health research, policies, and programs in low and middle-income countries must incorporate a far greater understanding of gender dynamics to be most effective. We think that it's important for donors to invest in rigorous, high-quality research and evaluations in low and middle-income countries to build the evidence base on the effectiveness of interventions to prevent and respond to mental health challenges faced by adolescent girls and boys. We also think it's important for donors to fund the development and implementation and/or scaling of effective strategies to promote positive mental health and well-being for adolescents, including those that address gender-specific risk and protective factors. As for policy, we feel that it would be important for policymakers to develop strategies to strengthen the health sector's response to the gender drivers of adolescent mental health within the context of a broader multi-sectoral strategy. We also feel that it would be important for policymakers to review existing policies to assess the availability of suicide prevention and mental health services for adolescents, implementation challenges, and whether policies address the gender drivers of mental health. Policymakers can also develop action plans and budgets to integrate mental health services in primary care settings and develop and disseminate national guidelines, standards, and supporting tools for the provision of gender-responsive mental health and psychosocial support services. So, with all these ideas in mind, I'd like for us to take a moment to think about this work through the lens of the Sustainable Development Goals. Sustainable Development Goal 5 focuses on advancing gender equality to provide an opportunity for renewed attention to meeting the healthcare needs of adolescents through prioritizing mental health on the global healthcare agenda and addressing the gendered drivers of mental health and well-being. We hope that by bringing together donors, multilateral organizations, program implementers, researchers, and those who are interested in these topics, that we can develop a research and programmatic action plan that will address the gender drivers of mental health. At ICRW, we hope to build the evidence, examine the data, and advocate for more rigorous and intentional research, programming, and policy making around gender and adolescent mental health. Thank you.